Good morning. Thank you for joining us for our Northern Light Health Good Health is Good Business Zoom conference. Spring is officially here today. Believe it or not, it is spring. Even with this weather, it's absolutely my favorite season in Maine. It is a season that brings us warmer weather and more reasons to get outdoors. And while we are eager to welcome the sunshine, especially today, we are not so eager to get back to the tick check routine. Today's panelists have prepared a wealth of information to share with you on the topic of tick-borne disease in Maine. We will learn about the changing landscape in Maine, Lyme and other tick-borne disease, employer considerations, and prevention strategies. I'm Karen Hawks, Vice President of Operations for Population Health at Northern Light Health, and I'll be your moderator for the next hour. Please join me in welcoming today's panelists. As always, I'm pleased to welcome back Dr. Jim Jarvis, Senior Physician Executive at Northern Light Health and the Director of Clinical Education at Northern Light Eastern Maine Medical Center. Dr. Jarvis will begin today's conference with a brief health update for us all. I'd also like to welcome Dr. Charles Lebelsic, a vector ecologist with the Maine Health Institute for Research, Dr. Scott Melton, a physician in infectious diseases at Northern Light Eastern Maine Medical Center, and Dr. Howard Jones, the medical director for Northern Light Work Health. Before we get started with today's panel discussion, I will read our legal disclosure. The information presented in this session is provided for educational purposes only and is not meant to substitute professional or medical judgment. Northern Light Health does not know the particulars of your situation, so the information presented today is intended to be general in nature and may not apply to every individual situation. Northern Light Health and the presenters make no guarantees or warranties regarding any information provided. This hour is intended for you, and we welcome and encourage your questions at any time using the question and answer function. We also want your feedback. I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input influences future topics. Now, I'd like to welcome Dr. Jarvis to get us started this morning with the health update.
Thank you, Karen. First slide. So I want to just give an update on where we are as far as respiratory illnesses go across the United States. I would love to say that I could see a trend here that shows that things are getting better. And it probably does show that because we have more states that are in the low and minimal categories. But you can see some states that back in February were in a lower category are now in a higher category and vice versa. The good news is that in Maine, respiratory illnesses seem to be on the decline, and that is good news. Remember, this is a conglomerate of respiratory illnesses, so that would be COVID, influenza, and RSV. And so it's all three of those together. And so next slide, please. So here in Maine, influenza-like illnesses, again, the big three there are COVID, influenza, and RSV, meaning that these are viruses that all cause similar type symptoms, particularly fevers, chills, and upper respiratory type symptoms. Obviously, there is a degree in differences between the severity of the diseases for those three. Again, you can see that we can see a steady decline in outpatient visits for influenza-like illnesses, and that's good news, but we are still way above where we were for this time last year. And I think that's the kind of the surprise for everybody is that we really had this lingering respiratory illness season this year. Hopefully we will continue to see that fall. Again, if we look at just influenza hospitalizations in Maine, similarly, they are higher than they were last year, but they are lingering on longer than we saw last year, where we had that huge peak in the early part of winter, but then a steady drop off. But it's good news again that hospitalizations in Maine are going down. Next slide, please. So I want to give some new information that came out recently about COVID vaccines. First and foremost is that the CDC made a recommendation just at the beginning of this month that all people ages 65 and older should receive one additional dose of any of the updated, meaning the vaccines that we gave out in fall of 2023 against COVID-19, and those would be either the Moderna, the Novavax, or the Pfizer biotech vaccines. So that's definitely new. It's also a different kind of recommendation that we've seen before because it's 65 and older. Before, we've seen these recommendations come out saying either 60 and over or 50 and older. Note that there is no recommendation for those individuals who may be immunocompromised. This is specific just for individuals over the age of 65, and that really is based upon the fact that the most of the hospital hospitalizations due to COVID-19 now are in the age category of individuals over 65. I also want to highlight two studies that were just recently published. The first was published in Heart, and that showed that for individuals who are up to date with their COVID vaccines, but who were infected with the virus, had a 55% decreased risk of resulting in heart failure from the infection and a 78% decreased risk of blood clots. That is really, really important because, again, I've heard people say, oh, well, why should I get the vaccine? Because people still get infected with the virus even if they've been vaccinated. Yeah, but it protects you against these really severe things and in a dramatic way. This is definitely most significant within the 30 days following the vaccine, but they've seen that benefits last up to a year, which really kind of ties into the fact that we think we're going to start seeing recommendations come out before next fall that everyone get an up-to-date COVID vaccine annually. And in fact, the CDC has requested of the makers of vaccines that they need to update the formulation of it so that it targets the current circulating variants that we see. The good news is that the past vaccines still work against those variants. And then the other study came out in JAMA, and it found that there was no evidence that messenger RNA vaccines against COVID caused an increased risk in stroke. And I really want to highlight this because there was a widely reported concerns when analysts who look at all of vaccine side effects had said they'd seen a signal marker, meaning just a little blip, they weren't sure if it was accurate or not, that suggested that messenger RNA vaccines may cause a slight increase in stroke risk. After actually doing a thorough review of that signal evidence, they actually found that there was no evidence that messenger RNA vaccines against COVID-19 caused an increased risk of stroke. And as we've reported here many times, actually, it is a far better thing to be vaccinated, even if there was that risk, because there's a much, much higher incidence of stroke for individuals who actually contracted the virus who had not been previously vaccinated. Next slide, please. So I wanted to give a quick update on measles because it continues to make the news and the headlines, and physicians across the country continue to get alerts from the federal CDC and here in Maine from the Maine CDC about measles. Thankfully, this is a graphic that shows all of the states that have had at least one case of measles since the beginning of the year. You can see that Maine does not, and in fact, all of New England seems to be pretty clear from that. But it is concerning because if you look at the graphic on the right-hand side, you can see that the number of reported cases has been going up since the beginning of the year, and that is extremely concerning. Most of these cases can be directly related to someone who traveled outside the United States, contracted measles there, and then brought it into the United States, and then unfortunately infected usually people who are not immunized, and most of the time those are young children. For those of you who aren't aware, because you might not have children or just don't remember when your kids got the vaccine, for the first year or so, most children are not vaccinated against measles. That usually happens between 12 and 15 months. And so therefore, we have already a population who is not vaccinated. So it's really, really important that everyone else get vaccinated. So my take-home message here is that individuals who have not yet been vaccinated against mumps, measles, and rubella really need to get that MMR vaccine because measles, unfortunately, is on the rise, and that is very concerning for all of us. I will say that the state has a very good process in place should we actually have a case of measles here in the state of Maine. We're already building relationships between our private enterprises and the state on how to handle that. And with that, I'll turn it back over to Karen.
Thanks, Jim. And I really appreciate you sharing the information about COVID boosters because we don't hear about that as often as we used to in the news, right, in the evening news. So that's important information. Regarding the measles, the increase in the number of cases has me questioning, are we at potential risk if we don't see these numbers start to decline of seeing variants within this disease that might make our vaccine less effective, or I know it's a little bit hard to predict the future, but you are a public health professional, so I'm sure you have an opinion on this.
Yeah, that's a great question, Karen. So measles is a DNA virus, not an RNA virus, and so they are extremely stable. And this is the reason why it's been, the vaccines work so well. So the vaccine that got started in the 60s against measles is actually very similar to the one we use today because there isn't much change in measles. And that's why vaccine actually works incredibly well to prevent diseases like this. So the change in the variant is probably not the issue. The issue is just that we unfortunately have a much larger population of individuals, particularly school-age individuals who are not vaccinated against measles or under-vaccinated against measles. And that just adds to the ability for this virus to spread. Measles is still considered the most contagious respiratory virus illness that there is in the history of all of time. And so that's the reason why it spreads. And again, we kind of talk about that really we need populations to have about a 95% or higher vaccination rate in order to keep measles under control. In fact, that's when measles was declared eradicated in the United States. As you can see, we are clearly not eradicated now. And the rest of the world is seeing the exact same thing. And in some underserved countries, unfortunately, they're seeing even more cases of measles, which again, with the way we travel nowadays, just brings it back home to us.
All right. Thanks so much, Jim, for joining us this morning and for sharing that information. It's now
My
my
pleasure.
pleasure. Yeah, absolutely. It is now my pleasure to introduce Dr. Chuck Lebelsic, who spends most of his time outdoors contributing to science, and we are fortunate to have Chuck join us today. I will also say we are especially fortunate because Chuck is recovering from surgery, but still was willing to join us and share a wealth of information to help educate us today. So thank you so much, Chuck, for joining us.
Yeah, thanks a lot. I'm going to caveat by saying I may have a stray cat crossing in front of the camera at some point. But our lab down at the Maine Health Institute for Research works on a lot of vector-borne disease surveillance and basic research into the ecology and public health relevance of ticks and mosquitoes. So for starters, what are ticks? Well, in addition to being our favorite wildlife species in the state of Maine, they're also an arachnid. They're not actually insects like butterflies and praying mantises, but they are arachnids that are more closely related to spiders and mites. And they had a worldwide distribution. And they're a very long existing organism being found as early as 99 million years ago, with evidence that there were actually some species that actually parasitized dinosaurs back in olden times. And so when you are getting a tick, there are some basic differences that you can use for helping to identify. The one that we primarily use a lot of is the one in the middle called the scutum or the dorsal shield. Depending on the tick species, this may or may not be a light or dark color. Generally, the tick that we have the most concern about in Maine, the black-legged tick, also sometimes known as the deer tick, has a black shield behind its head in all of its life stages. And so that's a very good way to characterize whether or not the tick you're finding on yourself, your kids, or your pets is actually a deer tick versus another species. The mouth parts, of course, are important because that is what actually goes inside of you when a tick bites. And the mouth parts with a tick, which will come into play again when we're talking about prevention. A lot of the mouth parts of the tick, if you see them very up close under a microscope, are not like a mosquito, where a mosquito comes in very quickly, takes a bite, takes a blood meal, and flies off. The ticks usually have a barbed mouth part, which means it takes them an awful long time to actually settle in and start feeding on you. Conversely, when the time comes to pull that tick off, a quick jerking motion, when you're removing a tick, will frequently result in the head of the tick being left behind under your skin. So we often advocate a very gradual, gentle tugging with tweezers, which helps to get those barbs out of your skin to remove all of the tick when it comes out. We have about 15 different species of ticks that we know about in the state of Maine and also the greater northeastern US at large, and also maritime Canada. But for us, we have two very common ticks that are encountered by people that are going outdoors a lot. The first is the black-legged or deer tick, and the second is the American dog tick. And there are some key differences about them. As I said before, deer ticks will usually have some kind of black on the back or dorsal side of the tick. In the males, that black shield actually extends all the way down the back, whereas the females have a smaller shield right behind the head. By contrast, dog ticks are a little bit larger, and they will always have some kind of white on the back. The males have these sort of lightning bolt or racing stripes that go in rough parallel lines down the back towards the hind end, whereas the females, instead of having a black shield or black scutum, will have a white shield. And even if you are pulling off engorged ticks that are completely filled with blood, those black or white shields behind the head are going to be visible. And again, a black shield indicates a deer tick. A white shield will probably indicate that it's a dog tick. Next slide. And so ticks come in various sizes. In some cases, when we're looking and talking about deer ticks, one of the most common things that we think about is that the tick is quite small. In the summertime, the life stage of the tick, known as the nymph, is characterized or commonly referred to as being the size of the head of a pin or possibly a poppy seed. The adult ticks, which we are seeing right here on this slide, are actually about the size of an apple seed when they are questing, looking for a host. However, when they start filling with blood, and this can take up to several days, they get about 10 times the size of an apple seed. If you want to use a food metaphor, to this extent, they get to be about the size of a large blueberry. So they get to be quite sizable. And of course, with people, the hope is that we find the ticks before they get to be that engorged on somebody. But certainly with our pets, which is always important to consider. If you guys have pets that are going out, both cats and dogs, they certainly can get ticks, obviously, but they are also a vehicle for bringing ticks into homes. And so certainly doing tick checks on your pets is going to be as important as doing tick checks on yourselves or your kids. But again, we ideally want to get the ticks off before they get to be about the size of a large blueberry, which would indicate that they've been feeding for at least a few days at that point. And so depending on the life stage of the tick, in general, it's not uncommon to hear about ticks, sometimes feeding up to about 10 days on a host. And again, that barbed mouth part helps this tick to stay in. And so if you were to look and compare a tick versus a mosquito under a microscope, you would see that the mouth parts of a mosquito don't have any barbs or recurved fish hooks. But ticks do, and that actually helps to anchor the tick under your skin and helps it to stay on its hosts for several days. Now, when ticks are feeding, they have a couple things going on that oftentimes don't make them as noticeable. One is that they are, as they're feeding, injecting an anesthesia into you, which is helping deaden the site of the bite so you don't feel it as irritatingly as you would a black fly or mosquito bite. At the same time, because these ticks can be on for quite a few days, there's an anticoagulant they're also injecting to you at the same time, which is allowing the blood to flow into them to get their meal. It keeps the blood flowing and prevents it from clotting. Now, common misconception, there's a bunch of stuff out there that talks about how ticks may be able to fly. They may get, launched up into the air, or that they climb trees. Generally that's not true. One of the big common misconceptions about ticks as well recently is that somehow there's a static electricity force that's causing them to levitate in the air and get onto people. Generally, there's a lot of misinformation about that. Ticks actually, one of the biggest ways for a tick to die, one of the biggest sources of mortality, is actually for ticks to dry out. So as a consequence, more often than not, ticks are going to be down low to the ground, where in general, it's a little bit more humid on the landscape. As you go higher up, be it on a piece of grass, on a fence post, on a tree shrub, you get access to more wind and potentially more sunlight, which is going to dry the ticks out. So in general, ticks like to be down low to the ground. And in many cases, most ticks that are encountered by people or pets tend to be at the knee level below, or roughly a meter in height below. And again, this is just a graphic showing that we have 3 of our most common species of ticks. And we've talked about the deer tick or black-legged tick in the upper left, and it's a male and the female, contrasted by the American dog tick, again, male and the female. And one difference about the seasonality of these ticks, which we may go into a little bit later on as well, deer ticks tend to have a varied life cycle throughout the year. And really, depending on the temperature, it's very common now for us to find deer ticks at almost any month out of the year, especially when we are seeing mild winters occurring more often than not in the coastal plain of Maine within about 5 to 10 miles of the ocean. But certainly even now into central Maine, we're having mild winters when the temps are getting up close to 40 Fahrenheit, and deer ticks can be active. By contrast, American dog ticks have a very short season. American dog ticks tend to be encountered really in an average year starting around the end of April, really starting to peak up towards the end of May, early June, going into July. And then these ticks are pretty much disappearing off the landscape by the end of July. And it is very rare to find them as you're going into August and September. These ticks, dog ticks, tend to be a little bit larger as well. They can be up to 1/8 to almost 3/16 in size. So again, just to keep in mind, if you're out in the springtime and you're encountering ticks that have some kind of white on the back, They're a little larger, under a quarter of an inch still, but larger than an eighth of an inch. And it's spring, April through June. There's a pretty good chance that you're going to be finding American dog ticks. And American dog ticks, from our perspective in public health, they are not a public health issue yet in Maine. As you go to the southern U.S., out to the western parts near the Rocky Mountains, they do transmit some diseases like Rocky Mountain spotted fever. But in Maine and in northern New England so far, they are just a nuisance factor and are not vectors of disease. The last tick on the slide is at the very bottom, and it is a tick that looks a lot like the deer tick. In fact, it's closely related. It's in the same scientific genus, Ixodes, but this tick is commonly called the woodchuck tick because of the common wildlife hosts that it feeds on. This tick is not an active quester. You don't find it out roaming in the woods, waiting to get on people and pets the way you do with dog ticks and deer ticks. But because it likes wildlife such as woodchucks, but also skunks, that may be very close to homes, especially if the animals are burrowing under porches, under decks, under garages, sheds. They can be frequently encountered right around the area of burrows. And so when we've been doing some work early on, we tended to find that domestic animals, especially cats that would be investigating these burrows, may acquire these ticks, but also kids that are playing down very close to the ground may also encounter these ticks. And in rare instances, this tick has been implicated in the transmission of a virus called Powassan virus, which has been seen a lot in the Northeast and Canada. Now, we do have some ticks that we consider to be exotic and not yet of a concern in Maine, but there is always the possibility that we will have them established. The first one on the left is called the Lone Star tick. Scientific name is Amblyomma americanum. And the Lone Star tick is a particularly aggressive tick that the normal historic distribution in the last several decades has really been in the southern U.S. There is some evidence to say that prior to colonial periods, there may have been some northern populations, but in general, this tick has normally been associated with the South. And we are seeing small inroads where this tick is creeping now into New England. In the last 10 years, it has gone from the mid-Atlantic to Rhode Island to now the coast of Massachusetts, indicating that it's slowly every year moving its way further and further north. It is an aggressive people biter and can be a vector of disease for both livestock and humans. It is one of the few tick species with eyes, and it has been reported that it will actually turn and follow you if it sees you walking in the woods. So if you need a greater idea of a horror story for ticks, this would be a good candidate. And where they become established, folks in Long Island, New York, for instance, will say that you can actually hear this tick. It's so abundant, you can actually hear it rustling in the leaves in the fall. So, a firmer, another sensory aesthetic to this tick as well. On the right, we have a tick called the longhorn tick, which was first seen in the U.S. in 2017. So it's a relatively recent tick to be discovered in America. It was probably imported on livestock from Asia. It has not yet been found to be a human vector of disease. However, at least in North America, but it is a heavy parasite of livestock and can cause mortality in livestock such as cattle and sheep, where it has become established. There are rare cases where it's been associated with disease in the Pacific as well, stretching down to New Zealand, but we have not found evidence of that disease is being transmitted here in the U.S. yet. So when we're talking about deer ticks, and a lot of this discussion today is going to be about deer ticks and the diseases they carry, since they are our most medically important tick. And deer ticks are not universally found across the landscape. They tend to have, and in a lot of ways, you can think of them as almost the Goldilocks syndrome, where they have habitats that they really like. And kind of like Goldilocks, they don't like it too hot, they don't like it too cold, they don't like it too wet, or they don't like it too dry. And if you're in a wooded forest habitat, where you have ample leaf litter, you've got a decent proportion of shrubs in the understory, and you've got a closed canopy. Normally, we think oak and maple stands being the dominant forest type for these ticks, but that's really the optimal deer tick habitat. And when you put all those things together, the leaf litter, the shrubs, and the leafy canopy, it provides a nice protective habitat for the tick. So it doesn't dry out from sun, and it has reduced exposure to wind, which allows these ticks to survive, especially during dry periods like our late summer in Maine. Now, seasonally, as I said, we do see ticks throughout the year. But for us, we have two really active cohorts of ticks, of deer ticks that we see that are of public health or veterinary health relevance. The first, which would be the light blue line, would be the nymphs. And the nymphal life stage, you can think of as almost the teenage life stage of the tick. This is the life stage because of its size. Again, the size of the head of a pin or poppy seed is most responsible for human cases of Lyme disease and other tick-borne pathogens. It tends seasonally to emerge around the middle of May, peaking in June and July, and then disappearing off the landscape by about August and early September. And this actually tracks very closely with a lot of the reported cases of diseases like Lyme disease and anaplasmosis. By contrast, when those nymphal ticks go down for the season in August and September, they will then emerge as the adult life stage, which is the one you see here in the red and black. These ticks tend to emerge in early October, peaking towards the 3rd to 4th week of October, right around Halloween, and then slowly trickling on into November, and then historically tapering off by December because of the cold and snow cover that we historically get. Now, in recent years, with milder winters, these ticks certainly have been active, and it is not uncommon to go out and find these ticks, especially in the coastal areas of Maine, even around Christmas or New Year's, if you're actively looking, or if you're out walking your dogs, for instance. In a normal year with a lot of snow cover and cold temps, those ticks will remain quiescent, however, in most of January and February, re-emerging when the thaw happens around March, and staying active into April and May until they eventually taper out and die off in the following June. So again, a brief summary of where you're going to find ticks, looking at the ecology of these ticks. The deer ticks, again, you're going to be looking at mixed forests with woodland edges, suburban landscapes with a lot of shrubs, activity any time that it is above freezing, with peaks occurring April or May, and then also in late October. By contrast, dog ticks are generally not as associated with forested areas. They tend to be very resistant to drying out, and this is the most common tick you're going to find in open grassy fields or things like blueberry barrens. So again, if you're out walking in a meadow or a field, April, May, June, July, or you're out picking blueberries, berry picking, and you come across a lot of ticks, chances are it's going to be these dog ticks that you're going to be finding. Again, the peak activity period for them is going to be April to August, with a strong peak in May and June. And then finally, the woodchuck tick, we don't really have a great idea. I mean, we have summer months down here as a period of activity, but that's based on when people find them. But again, they tend to be around the dens of their wildlife hosts, which could really be anywhere. But certainly that means they can come into close proximity around homes. We have seen, based on some anecdotal information looking at wildlife hosts, that these ticks actually can be active throughout a good portion of the year. For instance, we've looked at some wildlife species that have been coming, we've been able to look at in January and February, and found that these ticks were quite happy on the animals in their dens at that time of year. But because of the cold temps, it means it doesn't come into contact with humans at that time. So in general, woodchuck ticks, the biggest time of risk, again, would probably be your summer months in Maine. And now, when we look at where deer ticks are, we're still very much a changing landscape in Maine. And you can see from this map here, which is based on a submission program where people can submit their ticks at the town level where they're encountering them to the University of Maine. We actually started this program in 1991 and transferred it over to the UMaine Cooperative Extension in 2013, and they've been running it since then. And what we have really seen is that early on, the ticks were really established in southwestern coastal Maine. You can see a little darker clustering around the Portland area in Brunswick, and then also around Acadia National Park. Those were the early hotspots where those ticks have been found. And since then, they've spread across quite a lot of the state. And you can see from this map that we have areas in around Jackman in the northeastern corner, areas around Fort Kent, Madawaska, and Presque Isle, and Holton in Aroostook County, and then also areas around Eastport and Calais in the down east area where these ticks are appearing now. And unlike states like Rhode Island, Connecticut, New Jersey, where they're pretty much covering the entire state, Maine is still a changing landscape, and we do see each year more and more municipalities are encountering these ticks and finding them as their distribution spreads across the state. And so when we look at Climate change. Climate change, does get linked to incidents of tick-borne disease as well as also mosquito-borne disease. But climate change, in a lot of ways, I think of it as not the only factor at play. If you think about it, we really have, like, think of Lyme disease as a stool that you'd sit on with 3 legs. Climate being very important, one of the biggies. However, the available habitat as well is also important. Again, talking about that ability for the tick to dry out. So again, your deciduous forests, but also the wildlife hosts. And things like deer are incredibly important to the distribution and survival of these ticks. And so when we add those in together, we have 3 things that really contribute. Now, as far as climate goes, things like excessive precipitation, excessive humidity. So getting even your summer days, even when there may not be as much rain on the ground, but you have a whole lot of extra humidity on the landscape. And then higher temperatures. Again, the warmer the overall year is, the greater potential for ticks that you have. Generally, ticks will stop their activity at about 40 degrees Fahrenheit. So when the temps don't go below 40, you have a potential for tick activity. And this is, again, what we're seeing sometimes when we look at tick activity in the coastal areas of Maine, where it's now, unfortunately, not uncommon to have 50-degree temps even into January. And again, host populations, rodents certainly contribute to the overall burden of tick-borne disease because they are the reservoir for the pathogens. However, deer are the primary host for the ticks to get on in the fall when they need to get a blood meal to lay their eggs. So in many ways, you can think of it as mice and chipmunks are driving the overall infection rate, whereas the deer are driving the overall tick numbers on the landscape. And then again, your habitat's incredibly important. Where you have those forested areas that are very protective for the ticks, ticks survive really well. And so to some extent, we are seeing a gradual warming going on. This is a map showing some previous data, some relatively current data, and then kind of expanding out some ideas about how the temperature may be changing in Maine based on some climate models from the University of Maine and the Maine Climate Council. And what we can see is that over the course of our degree days, this is our accumulated degree days. Those of you not involved with agriculture, degree days are kind of the amount of days of a particular degree over a certain threshold that organisms need to grow or expand. For plants, obviously, this is important because you want to be able to plant your vegetables, your gardens, and know when your crops are going to become active and produce. However, we actually use the degree day model also in regards to ticks. And generally, the higher the certain number of degree days, the better off the tick population is going to be. And really what we're seeing here is on the map on the left, those areas where it has the coolest colors are indicative of lower degree days, which means the ticks may not be able to survive as readily or may be able to establish their populations readily. That has gradually changed. And you can see from the maps as you go further and further to the right that those blue areas are shrinking, being taken over by much more warmer areas, which means it may be more conducive to the ticks. And so the prediction is that as we go further out towards 2040, we're going to have a much warmer sense for Maine, which may make it more hospitable for the ticks in a year-round basis. And we have some common diseases in Maine. I believe this is where my portion is going to be ending, and I will pass this along now to Scott Melton.
Thanks, Chuck. And I'm going to ask Felicia just to skip ahead. We'll definitely talk about prevention, perhaps, towards the end of the hour. I will say so much information, Chuck, that you just shared. I feel like we could have another session on this topic. Who knew there was so much information about ticks, and I feel like they're crawling all over me. I don't know if anyone else in the audience does. But with that said, I am so pleased to welcome Dr. Melton, and Felicia will have to kind of play with the slide deck to get you to your TED Talk. So here we go. Welcome.
Hi.
Thanks for joining us.
Hi, everyone. Thanks for having me. Yeah, my name is Scott Melton. One caveat, I did my training in
Scott. Oh, okay. Sorry. I don't know if it was just me, but you cut out there for just a minute. So perhaps start over, and it could have been me, but
Okay, can you hear me now? I'm sorry.
yes, I can.
Okay, so yeah, I did my training in New Orleans where we don't have the deer ticks, but as you can see from this picture. Next slide, please. Okay, hold on 1 second.
Technology, right, on a snow day?
Is this better?
We can't hear you as well if you speak up. Your headset seemed to be working, Scott, but it was cutting out. I don't know why.
How's this? Is this better?
That's great.
Can you hear me now?
Yes, we can hear you.
All right, sorry about that. Sorry about the issue with the headset. So three of the diseases that we typically see here in Maine, second from the deer tick, are Lyme disease, anaplasmosis, babesiosis. I'm going to focus mainly on Lyme disease, but we will touch base on the other two, anaplasmosis and babesiosis. Next slide, please. And then some other ticks that that Chuck was talking about. We have the dog tick, and dog ticks can carry disease, but we're not seeing those diseases in Maine. Two of those diseases: Rocky Mountain spotted fever, tularemia, which is another bacterial infection. Again, they're diseases of concern, but we haven't seen them in Maine yet. The woodchuck tick has been associated with cases of Powassan virus. And Powassan, we do see Powassan in the New England region, and it does happen in Maine fairly, but it's extremely rare still. And then the Lone Star tick, as Chuck was talking about, more the southern, that's more what I dealt with down in Louisiana. And they cause there's a couple diseases that they cause. One is ehrlichiosis. Another one is tularemia and heartland virus. And as with the Lone Star tick moves their way up into the New England area, I'm sure we're going to be keeping an eye on those. Next slide. So Lyme, also known as borreliosis, is caused by a bacteria. It's what we call a spirochete, which means it's a corkscrew-shaped bacteria named Borrelia burgdorferi. It's named after the guy who figured it out, Burgdorferi. It's geographically localized, like I said, mostly up in the Northeast, the upper Midwest. Traditionally, about 20 to 30,000 cases reported annually, although this seems to be kind of tracking up over the past few years. 95% of cases occur in 14 states, again, along New England, in the upper Midwest, mid-Atlantic, and around coastal lake and river environs, which of course we have plenty of here in Maine. Next slide. So Lyme disease presentation. So typically with Lyme disease, what we do is we break it into two main groups. There's early Lyme, which is, within a few days after the tick bite, up to a week after the tick bite. And then if the Lyme if it isn't treated appropriately, sometimes it can develop into late Lyme. And so when these early stages, we see certain things like the bullseye rash. The medical term for that is the erythema migrans. And that is indicative of early localized disease. You can also have some early disseminated disease where, instead of the bacteria staying around the initial tick bite, it spreads out a little bit, so you can get multiple of those bullseye rashes or multiple erythema migrans. You can have some cardiac involvement, which we're going to talk about in a little bit, and you can also have some neurologic involvement. And then as Lyme progresses, as it's not treated, so weeks later, you can progress into late Lyme disease. The most common manifestation of that, as we'll see in a second, is going to be Lyme arthritis, but you can also develop, rarely, really rare, you can develop some encephalitis, encephalopathies, which are just some brain dysfunctions. And in Europe, because there's actually a bunch of different bacteria that cause borreliosis. There's different species. In Europe, they actually see some dermatologic issues, such as this issue on this patient's ear. That's secondary to Lyme disease. Can we go forward? Thank you. So from the CDC here, the relative frequency of clinical features among confirmed cases, about 70% are going to have that bullseye rash. So an important aspect to remember is, well, it often is there. It's not always there. So you got to keep that in your mind. We talked about the Lyme arthritis for late Lyme disease. You know, if it progresses to late Lyme, about a third of patients are going to develop a Lyme arthritis. And then some other things we see the meningitis, encephalitis, we see facial palsies. We see nerve issues with the radicular neuropathies, and we can see the heart issues, which are pretty rare, about 1% of the time. Next slide, please. So here's a patient. I always like to, when I do these talks, is like, hey, let's play doctor. So we have an 18-year-old male. He lives in suburban Maryland. He shows up to his medical clinic in July. So as you see, the timing is important, and he's complaining of a rash on his side here, and he's got this circular rash that's kind of, at first it wasn't that big, but now it's gone up to about 12 centimeters, so it's pretty big. He works as a landscaper. He doesn't have any symptoms, but he says he did note a tick bite about 10 days ago. When he went to the urgent care, they gave him some Keflec, which is an antibiotic we typically do for skin infections, and it didn't really do anything. And so this would be a classic presentation of early Lyme disease. Next slide. So yeah, this is early localized Lyme disease. This is what we were talking about with the erythema migrans. The classic presentation is you have this bullseye lesion with some clearing in the central area. You don't always have that. Next slide. You can have no clearing in the central area. You can have this little punctate lesion in the middle. That's where the tick actually was latched on at, and you're seeing some local reaction to that. Next slide, please. And so this primary lesion is going to occur within 3 to 30 days, average of 7 to 14 at the site of the tick bite. And that's the key, is that this is localized. Some things to think about if you're trying to figure out the diagnosis, some other things it could be cellulitis, which is just a bacterial infection of the skin. Tinea, which is a fungal infection such as ringworm, erythema marginatum, again, another medical term for basically it's a rash that you see with some types of strep infections. And some people just have what we call tick hypersensitivity. They just develop a big, circular rash from a tick bite. Now, the diagnosis of early Lyme disease with this bullseye rash, with this erythema migrans, it's what we call a clinical diagnosis. You don't need any testing. We don't recommend any antibody testing, because chances are at this point it's going to be negative anyway. And so the recommendation is just to go ahead and treat. And so most of these lesions are going to have minimal local symptoms, and and about 70% of the patients are going to experience some flu-like symptoms. They're going to have fevers, chills, joint pains, muscle aches, headache, and this is pretty typical of early Lyme disease. The treatment, next slide, please. The treatment is pretty straightforward. It's just oral antibiotics. The go-to that we use is a pretty cheap antibiotic we call doxycycline. You're going to take 100 milligrams of that twice a day for 10 days. Now some patients can't take doxycycline, particularly pregnant women. We try to avoid doxycycline. And so we can do amoxicillin, 500 milligrams for 2 weeks, or another, if you're allergic to penicillin, we can do another antibiotic called cefuroxime, again, treat for 2 weeks. If you're allergic or have issues with all of these, an alternative is also azithromycin for 7 days. But most patients, I go ahead and put on doxycycline for a total of 10 days, and they do just fine. Next slide. So here's an example of that early disseminated Lyme disease, as you can see, where you have multiple of those bullseye regions. These patients are typically always sick because the bacteria is just kind of spread all over the place. And so they're going to have fever, really bad flu-like symptoms, the muscle aches, the joint aches, they're going to have headaches. And then what's interesting is you can often figure out which is the primary lesion because it's often larger than the satellite lesions around there. So I would say that would be the primary, and then these would be some more of the secondaries. Next slide. Another thing that you can see in about 25% of the patients with early Lyme disease is you can see a facial nerve palsy or a Bell's palsy, sometimes is what it's referred to. And again, because the testing can take 4 to 6 weeks to turn positive, we say if you see this, just go ahead and start treating for early Lyme disease with the doxycycline like we discussed before. Interestingly, though, the thing you got to keep in mind is Lyme was only discovered in Lyme disease as an entity was only discussed first in 1977, and the bacteria wasn't discovered until the 1980s. And then but people have been getting Lyme disease for thousands and thousands of years. And what's interesting is most of these patients, even with the facial nerve palsy, would get better without antibiotic therapy. They would just get over it. The issue, though, is we still give the antibiotics, of course, because we want to prevent later disease. We want to prevent those manifestations of late Lyme disease. Next slide, please. So here's a patient that I've actually seen this, a patient like this. It's pretty classic presentation. You have a 19-year-old male. He's at a Vermont college cafeteria, and he collapses when he goes outside. He hasn't been feeling well for about a month. Just like I said, low-grade fevers, muscle aches, joint aches, just not feeling good. And when they did an EKG on him, they found out that he was in what we call a complete heart block. And this can sometimes happen with Lyme carditis. The interesting thing about these kind of patients is they often look fine. It's just that their heart rhythm is very scary if you're a medical professional. If they are having some issues keeping their blood pressure up or something, they may need a temporary pacemaker. But typically, this is also going to resolve within a few days of antibiotic therapy. And they do just fine. One of the issues, so you don't need to put a permanent pacemaker in them or anything like that. You just start them on some antibiotics. Next slide. So if they're doing, outpatients can be treated with doxycycline. Honestly, most of these patients are treated in the inpatient setting, at least initially. Typically, we'll put them on an IV antibiotic called ceftriaxone. Now, once they get better and once we see some improvement in their EKG, we typically, in their heart rhythm, we typically transition them to oral antibiotics, to the oral doxycycline, and then we just treat them for 14 to 21 days. Okay, and so moving into late Lyme disease and Lyme arthritis. So Lyme arthritis typically is going to be what we call a mono or a oligoarthritis. What that means, it's typically only going to typically affects large joints. It doesn't typically affect the fingers or the toes or the ankles. Typically, it's going to be like knees, elbows, shoulders. Knees are the most common. And typically, it's going to affect either one or just a few joints. It's not going to be diffuse arthritis throughout the body. Other large joints are possible. And then I've never seen one, but they do talk about in the literature about temporomandibular joint, jaw, Lyme arthritis. And this is one of the reasons why we do recommend treating, because this can affect 50 to 60% of untreated patients. And typically it's not a very fulminant disease. It typically waxes and wanes. It kind of comes and goes. And it can happen over weeks to months. And it'll, like I said, without antibiotic treatment, it's going to kind of it'll flare up, it'll get better, it'll flare up, it'll get better. Next slide, please. And so the treatment for this, initially we do oral antibiotics. We'll do the oral doxycycline for 28 days. And then one of three things is typically going to happen. You're either going to get better and it's going to go away. You may have a partial response where there's just some mild residual joint swelling, mild pain, or you may have a minimal response where nothing really happens. For the partial response, we can do one of two things. We can either repeat the oral regimen for 28 days, or we can try IV ceftriaxone for 14 to 28 days. Honestly, I typically go for the 28 days of doxycycline because it's just a little easier to manage. Now, if you have minimal response, or if you didn't respond to the second course of oral antibiotics, then what we would recommend would be an IV antibiotic, IV ceftriaxone for 14 to 28 days. Next slide, please. Now, the issue is you can have this issue of post-antibiotic Lyme arthritis, where despite proper treatment with antibiotic therapy, approximately 10% of patients with Lyme arthritis aren't going to respond. It's felt that the body kind of develops an autoimmune response to what's going on inside the affected joint. And so for these patients, we don't recommend further antibiotics. We actually recommend either medications that we typically use for rheumatoid arthritis, or as a last resort, if that doesn't work, we would talk to our friends in orthopedics and see about them going in and actually removing all the lining, what we call the synovium of the joint, to see if that helps. But again, as you can imagine, that's kind of a last resort. Next slide, please. And then late Lyme disease neurologic symptoms. Now, this is rare. You can get what's called an encephalopathy, which is where you have, they have trouble with, understanding the situation, understanding where they're at. It's not really the typical thing like we talk about with brain fog. It's usually more severe than that. And it's often due because you're just super sick, and it's, rather than a true central nervous system infection. It's, more that your whole body is pretty sick, and so your brain's just not working as well as we'd like for it to. Rarely we can see an encephalitis where you have, neurologic and cognitive dysfunction, and then on imaging we actually see changes consistent with encephalitis, where we see changes in the brain, we see changes in the composition of the CSF fluid, and often if we take a sample of that cerebral spinal fluid, we'll see white blood cells in there, and there'll be a positive Babesia antibody in there. And then there's another neurologic issue of peripheral neuropathies. Now, sometimes you can have just a single neuropathy. Sometimes you can, which is just pain and paresthesia in a certain nerve. Sometimes you could have multiple areas, and sometimes on imaging with electromyograms or neuroconductive tests, you can see some axonal changes, but we don't see that very often. Next slide, please. And so as far as when we treat Lyme disease, one of the things that we need to do is we need to manage expectations, because, despite appropriate therapy, you can still have some lingering symptoms for quite some time after a case of Lyme disease. So when we look at this table over here, they're looking at patients having symptoms and at what time point they're having symptoms. And so when patients have that bullseye rash, about 73% of them are going to be symptomatic. They're going to have the joint pain, the muscle aches, the chills maybe. After about 3 months, that drops down to 24%, but still about a quarter of those patients are still going to have some symptoms. And at greater than 6 months, even about greater than 10% are going to have some lingering ongoing symptoms. However, around 15 years, it kind of drops back down to baseline. It kind of drops back down to the general population. So, the antibiotics are going to help, but it may not make you feel completely better within 2 weeks. One thing that we do know, though, and we've done several studies looking at this, additional antibiotics, longer courses of antibiotics really don't make any difference in these symptoms. So we don't recommend that. We actually just recommend, symptomatic management and supportive care. And, and these post-infectious syndromes, they're not unique to Lyme disease. You'll see them sometimes, okay, big case in point, long COVID, which we're still working out. This would be like a similar post-infectious syndrome. So it's not unique to Lyme disease. Next slide, please. So chronic Lyme disease. So this is a vague term, it encompasses a broad range of symptoms. It's the brain fog, the difficulty concentrating, continued diffuse joint pain or diffuse muscle aches and stuff. Often this is without a good clinical history consistent with Lyme, and a lot of times they don't really have a lot of reliable evidence for Lyme disease by laboratory testing. And the thing that happens that I've seen in my practice a lot of times we sometimes or not, well, sometimes we anchor on this diagnosis and we miss out on some other legitimate diagnoses, such as multiple sclerosis, amyotrophic lateral sclerosis, some autoimmune disorder, Parkinson's. You know, there was recently a paper that came out in 2019 that, you know, said about 80% of the time this was misdiagnosed, and it turned out it was more like an autoimmune disease or something else. Next slide, please. As far as Lyme disease prophylaxis, so you've been bit by a tick. Oh no, what do we do? It's the first thing we got to do is we got to figure out if it's a high risk bite versus an equivocal or a low risk bite. And a high risk tick bite is, first of all, the tick was found within 72 hours, that the tick bite was from a deer tick. And so being able to figure that out will help you out. That it occurred in a highly endemic area. And so that's given. We do have these ticks around. We are in a highly endemic area. And then that the tick was attached for greater than 36 hours. And the reason we add that is that the bacteria that cause Lyme, the Borrelia that cause Lyme, actually live in the tick's gut. And they have to make their way, they have to travel from the gut up to the mouth parts. And it can take anywhere from 24 to 36 hours. But, you know, if you have all of those criteria, then we certainly recommend a prophylactic dose of doxycycline, one time, 200 milligram dose of doxycycline, of course, after removing the tick, get rid of the tick as well. Otherwise, we kind of recommend a watch and wait, you know, especially if, you know, you're in that open field picking blueberries and you weren't sure it was a deer tick, could have been a dog tick. We often don't recommend doing the doxycycline if that's the case. Next slide, please. All right, excuse me. So I briefly wanted to talk about Lyme testing a little bit because it's not a simple thing. There's a little nuance in interpreting. So one of the issues is the bacteria that causes Lyme disease, Borrelia, doesn't get into levels high enough that we can actually directly detect it. It's very hard to culture in the microbiology lab. It's very hard to see. And so what we have to do is to look for Lyme disease, we look for our evidence of Lyme infection. We look for antibodies that your body is making to Lyme disease. And it's a two-step process. The first is a screening process that's very sensitive, but it's not very specific. You can have a lot of false positives with that. And so if it comes back positive, we reflex it to what's called a Western blot, where we look for specific proteins in those antibodies. And it's not as sensitive, but it's much more specific. The issue with that test, though, is it's not a simple yes or no test. You have to have a certain number of what we call bands and a certain pattern to be positive. So just because you have a positive screening antibody doesn't mean it confirms the diagnosis of Lyme disease. And even if you have a positive Western blot with just a couple bands, that doesn't confirm that you have Lyme disease. That just, you know, it requires some nuance in the interpretation. All right, next slide, please. And then just to briefly touch on a couple of the other diseases that we see with the deer ticks, anaplasmosis. This is a bacteria that is also carried by those ticks. It actually goes into your white blood cells. It can cause some significant symptoms such as fevers, chills, muscle aches, nausea, abdominal pain, headache. Less commonly, you can have respiratory symptoms, kidney failure, cerebral issues. So the nice thing about that, though, is it's treated just like Lyme disease. It's treated with doxycycline. So, you know, we just put you on that. And yeah, it can be severe when you see it. Next slide. Another thing that ticks can carry in Maine is babesiosis. This is actually a parasite. It's a parasite that infects red blood cells. And so it can cause fever, chills. It can cause a low blood count because it destroys red blood cells, headaches, severe malaise. I've seen joint aches. Highest risk people with it, elderly people, people without a healthy spleen, people who are immunocompromised. These can have severe cases of babesiosis. And so for most patients, actually, if you don't have those issues, there's no treatment. We just treat you supportively. If you do have those issues, we do have some medications, a medication called atovaquone and another one called azithromycin that we can put you on and get you through that. Next slide, please. All right, so there we go.
I'm muted, apparently. Thank you so much, Scott. I want to say we are kind of being a little flexible today because we had so much content. We didn't have an opportunity to get through it. I hope you have taken as much away from this hour as I have. Just so much information, and again, we could go on for another hour. It's just incredible. And so I just want to thank Scott and Chuck for preparing that information, Dr. Jarvis for joining us, and certainly Dr. Jones is going to be available for any questions post-conference for those of you who have questions specific to workers' comp. I will make sure I work with all of the panelists to answer the questions that we have received in the question and answer function as well as the chat. And we have all of your names and emails addressed, so we will send the responses to you and also post them online with the information that we have available on our website. Again, this is a recorded session, and the link to that is in the chat for you, but we'll include that in the email you will receive either later today or tomorrow. But I appreciate Chuck and Scott and Dr. Howard and Jim's flexibility today so that we could make sure we got through the content that we thought was priority today. Please consider joining us April 25th. We'd love to see you. The topic is around corporate responsibility for climate resiliency and sustainability. It's going to be a fantastic session. We have some community members as well as Northern Light Health at the table to talk about this important subject. And in celebration of Earth Day, which is on April 22nd, please be sure to share the invitation when you receive it with anybody in your network. We'd love to have them join us as well. And also take time to complete the post-event survey today. That information and your feedback is so important to us. So thanks for sticking it out with us a few minutes late. I want to thank again all of our panelists today. So much information, and you'll hear from me so we can pull together some answers for these folks who have been very engaged for the last hour. So thank you and have a great day. Drive safely.